AHE, ASTM, X12 in the US, CDISC for research, GS1. Anybody know what GS1 is used for right now in Saudi Arabia? Supply management. Marking identifiers or identifying medications. You know what the problem is? They didn't put the barcodes on the boxes. Right? So they're going to have to fix putting those they've got identifiers for all the medications now, but you can't actually look at the medication and find out what it is. So they're working on fixing that. But you have all these different standards. It becomes difficult to figure out what you're going to do. This is part of what's happening in this eHealth program right now, is we're identifying and we're selecting the standards. And we're trying to fit them all together into an architecture. So, how do you select standards? There's so many to choose from, and they're all good, and they all do the job. You have to have some principles for selecting standards. This actually comes from work that was done jointly in the U.S. Health IT Standards Committee. It's a national advisory committee to essentially the Minister of Health in the U.S. They call it the Secretary of Health and Human Services in the U.S., but it's the Minister of Health. Okay. They advise the minister on what should happen. So there's a clinical quality work group underneath that standards committee that developed this set of principles. And they developed this set of principles because I told them, when you're going to select standards, you need to have some principles to work from. And they looked back at the 10-year history of the national program in the U.S., and they came up with this great one-page set of principles that you can use for figuring out what you need. Does it do the work? Has it been used in the past? Is it something that I can buy? Is it something that's built into products that I can buy today? I talked about, you're going to implement Cerner. Does Cerner implement the standards? If Cerner doesn't implement the standards, does it make sense for us to use them here? So this is some of the things that we have to look at in identification. Can it do what we need it to do in the future, or is it able to transition from where we were there just a moment ago to where we want to be in 5 years? Standards aren't the same, they change. They advance just as technology advances. So it has to be forward-looking. It has to work with your architecture. So if you have a standard for the width of your train wheels, it should certainly work with the width of the train track that you're on, right? Because if those two pieces don't go together, and that's a common example that's used in standards, because in the U.S. we had 10 different widths for railroad gauges until we finally consolidated to one. And so you'd get somewhere and you'd have to stop and then change engines and cars and everything else because the track widths were different. Okay, so it has to fit into the architecture. And if you don't have an architecture, if you didn't plan an architecture, guess what? You have one anyway. Because you've designed your system to do certain things. You built in constraints. Your architecture's whatever framework's there, and it may be rickety, but it's still an architecture. Okay? And is it easy to use? Can you learn how to do it? If the standard is tremendously complex and you need a PhD to implement it, how easy do you think that's going to be to train up all of the PhDs that you need to make all this stuff work? And maybe it's not PhDs, maybe it's health IT geeks like me that you need to train up. You've got to have standards that are easy to learn and for which there's plenty of information around. So we have another problem with standards. Not only do we have a bunch of standards, but we need all of these because they do different things. I need to talk to the RIS. That uses HL7. I need to talk to the PACS. That uses DICOM. I actually need to have those two systems talk to each other. How do I do that? Enter profiling bodies and enter national specifications. The idea behind profiles is that you're combining standards to meet specific needs. So more than a decade ago, Radiological Society of North America was working on a problem. RIS was using HL7, PACS was using DICOM, the modalities, the X-ray systems and the CT systems and the MR systems were using DICOM. So I could make the DICOM, the MR talk to the PACS, but then I somehow needed to get the order from the RIS to the PACS. And I needed to make that work. And I needed to connect these things together over a network. And I needed to have communication protocols to do that. So the RSNA formed something called Integrating the Healthcare Enterprise, which they've done in partnership with the Health Information Management Systems Society. And they formed something called Integrating the Healthcare Enterprise. And what they built more than a decade ago was IHE's radiology scheduled workflow. Now, a decade later, scheduled workflow is built into just about every RIS and PACS in many modalities that are commercially sold in the marketplace. And it's specified in RFPs that you must conform to this set of standards. So the idea behind the profiling bodies is that they tell you how to put these things together. Right? And one of the things I always say, the problem with standards, they're like potato chips. You can't eat just one. You need them all. You've all used the web. Do you know how many standards are involved in terms of being able to see that information? There's a standard for how you describe the colors on the page. There's a standard to describe how those information is laid out on the screen. There's a standard to describe the format of the information as it's sent back and forth between the servers. There's a standard to describe the messages that are passed over the network communications. There is a standard to describe that protocol stack, and actually there's not just one, because you have TCP, Transport Control Protocol, and that's built on top of another standard called IP, or Internet Protocol. Okay? And that's built on top of another standard called Ethernet or Wi-Fi. It's all the 802.11 family of standards, and you actually don't even need to use those. You can use many of the 800 series of networking protocols. And over top of that are standards on the kind of wires you have to use, or Wi-Fi, the radio communications that you have to use, and all the way down. It's anybody in here the idea that, you know, the Earth sits on the back of a turtle? And this woman was explaining this to somebody, and he said, well, what does the turtle stand on? It's another turtle. He says, well, what does that stand on? She says, you can't confuse me. It's just turtles all the way down. It's just standards all the way down. Okay? And then you get into national specifications. And so you have the idea with national specifications is you need to take the standards that are being used now internationally, and you need to adapt them to your own national requirements. You need to capture the nationality of the patient. That's a requirement in some of the Saudi regulations somewhere. You have to capture this, and it has to be captured according to, or should be captured, so using the same set of nationalities that are used by the Ministry of Interior. There's other information that you have to capture or exchange. There's a current discussion right now underway about, right now there's this big push to use ICD-10 Australia modifications in Saudi Arabia for capturing some information. There's also a question of whether they want to use SNOMED CT for that. So that's a discussion that's actually happening is what's going to be the standard for describing problems. You know, now ICD-10 and SNOMED, they have slightly different purposes. They're not terribly aligned. But ICD-11 that WHO is defining is actually integrated with SNOMED CT. So either way you're going to wind up with SNOMED. It's just whether it's going to happen now or sometime in the future. And ideally, when you're doing this, you've got a plan, you've got a national infrastructure you're trying to get to, and you want to use existing standards and profiles. And this is why the ministry has invited me and many of my colleagues here. I actually have one of my colleagues, Rahik Al-Harbi, working with me at GE on some of this work. And using these international standards, but restricted to Saudi needs. That's part of the context. The context of use, the scope, is Saudi. We're going to be working with SASO, Saudi Standards Metrology. I had to actually go look that up. Measurement, right? And quality organization. Formed last year was the National Deployment Committee of IHE for Saudi Arabia. So it's IHE Saudi, and we're working with the Ministry of Health. Now, what's missing from this picture is Health Level 7. We need a Health Level 7 Saudi affiliate. Okay? That's actually in the process of being formed under SASO. I'm sort of leading that effort up. If you want to be involved and learn more about HL7 and you would like to see a national body in Saudi Arabia that can help you, that can actually bring to you the HL7 educational content, please talk to me over the next break because I have forms for a petition to form an HL7 affiliate and would like to get as many signatures from people who are interested in learning more about HL7 and participating in the national standard setting for HL7 as possible to convince HL7 that this should be done. We have SASO, who's willing to host the organization. We have MOH, who's willing to participate and bring its resources. But we need to have more than just the government involved. We need to have people here who are actually going to be doing the work engaged. So now I'm going to put my HL7 hat on. You can see it in its bright red. And talk to you, and I'm going to go through this quickly, talk to you about clinical document architecture. So this is a standard, and all of these slides are going to be made available. This is a standard that uses XML, Extensible Markup Language, to do basically four things: communicate, ensure compliance, be credible, and be complete documentation. I had an HIM director once say to me, if it isn't documented, it didn't happen. When Joint Commission comes in to accredit your hospital, if you don't have the documentation that you're doing what you say you're doing with the patients, nope, didn't happen. CDA is a standard that helps you by setting context, by providing the information, by making it possible to locate this data. Okay, so now we get back to the documents, and that same HIN director said, and with the documents, if I can't find the document, it might as well not exist. And if the document doesn't exist, the work didn't happen. So you have to be able to find it. You have to have a standardized way to find it. The problem we have with healthcare documents today, even when they're electronic, is if you put them in a word processor, 10 years from now, is that same word processor even going to be around? How many people here have used WordPerfect? It's always a good question to ask in an audience because there's usually at least one person that raises his hand. In the U.S., if it's the federal government, everybody raises their hand. Okay, many state governments too. It was a very, very popular word processor. 15 years ago, guess what? Some folks are still having to go back to DOS computers to use WordPerfect to be able to get to the old documents. Why? Because it's not standards-based. So the idea with CDA is it's standards-based, and it gives you access to all of the documentation that you have to maintain, that you have to use to prove that you did the work for your accreditation or for your regulation. And you can have this information in two ways. You can have the narrative, right? How do people write documents today? They pick up the phone or they pick up a microphone and go, and it's about takes that long. Right, this is an ED report, and it goes somewhere and it gets transcribed and it comes back and it's in a Word document. Okay, you've got the narrative coming in there. You also have machine-readable information. Right, the machine's not going to read the human saying whatever they say. But it can look at the information. It can use many different ways to get at specific codes to say, well, the patient has hypertension. And he's obese. and he should stop smoking. Okay? So you can put that in the document as well in CDA. And so you get these multiple levels of information that you can store. You have the human readable, you have the structured content, so now it looks like HTML. You've got different sections, and you can have tables and lists to organize the information. And then you have the machine-readable entries, which gets you what you need when you want to get to that point of doing surveillance, or when you want to get to the point of being able to say, well, what's the immunization this patient's gotten? So with this, we're also dealing with, well, what kind of information do we need to exchange? So we have a standard in the U.S. It's called the Continuity of Care Record. It's a set of functional definitions of the information that needs to be exchanged. And that was created by ASTM. And ASTM and HL7 came together and created the Continuity of Care document that says, well, here's how that looks when you use it in CDA. This is one of the implementation guides that I helped write in HL7 that provides a snapshot in time that talks about the patient's clinical, demographic, and administrative data. So this is another standard. If you go to that link, and as I said, these slides will be made available, but if you go to that link, you can actually see one on the web. Geek Doctor. So there were 3 blogs that Bill mentions. It was his. It was mine. There's another fellow by the name of John Halamke. He goes by the name Geek Doctor on Blogspot, and he writes about healthcare. He's a CIO at Beth Israel Deaconess. He's a CEO somewhere else, and he's also essentially the vice chair of that standards committee that I talked about earlier. So he posted his records in that format. So what is it trying to do? It's trying to capture the pertinent and relevant information that needs to be exchanged between healthcare providers. Who decides pertinent and relevant? Who could tell me who would decide pertinent and relevant? Oh, come on. Really? You do. The physicians do. The doctors do. The nurses decide what's the relevant information that needs to be captured. This is not a machine decision. Okay? You know what's going on with the patient when you document this information. So you have a whole bunch of essentially administrative header information, and then a lot of different pieces of information. Now, many of you who've been involved in developing or writing clinical notes, this is all going to be familiar to you. There's nothing new here in terms of what's being communicated. Where is CDA being used? What standards are we selecting? In Saudi Arabia, CDA, and the Continuity of Care document, and IHE profiles. So these standards build on top of other standards. Remember I said turtles all the way down? Here are more turtles. Okay, and we have not just healthcare standards, but also other international ICT standards. We're building on XML. We're using XSLT. Guess what? There's even a version of HTML called XHTML, which is the XML flavor of HTML, also supported by your browsers. So this is something that is used worldwide. It is the most popular standard worldwide. I should have put this reference on the end of the slides, but I did not. If you go to tinyurl.com/wwxds, any of those little pinpoints on that Google map that you see that have a little black dot are using CDA. It's all over the U.S. It's part of our national standards. It's being adopted now in Canada. It's used in the UK. It's used in France and Italy. There's a 17-member organization called EPSOS in Europe that involves 17 member countries. I think it's now 27, called EPSOS, that's using CDA. And you can do this incrementally. This is important. You'd be able to do this incrementally so that you can get where you need to go. And so if you overshoot the mark, you can always pull your scope back to say, well, okay, we're maybe not getting machine-readable data today. We'll just take the narrative. So I'm quickly going to put another hat on and talk about integrating the healthcare enterprise. So this was started more than a decade ago by RSNA and HIMSS. It is now a separate business entity, integrating the healthcare enterprise incorporated. Public organization by health professionals in industry to improve the way we exchange information, using multiple standards like DICOM, like HL7, to exchange information. And the point is that if you use the IHE profiles, you have a way to take all of these different pieces, put them together to support a specific use case, and support eHealth projects. So we could call this immunization, we call this medications, clinical notes and summaries, sharing of labs, KSA-wide patient identifier, etc. This is what we're trying to do here. And so IHE's been around for more than a decade. Continua, more recently, I'd say in the last 5 years, showed up on the front to do this for medical devices and home healthcare devices. Right? So now I get a glucometer, and that glucometer is a computer. It's got a computer in it. It's got chips in it. I can stick a card in and store information, and then take that information to my doctor. I've got a blood pressure cuff. It's actually sitting back in my hotel room so that I can take my blood pressure. Okay, that guy who has hypertension and is obese and should stop smoking. Yeah. So I can take my blood pressure, okay, and I can store that on my iPad. I need standards to be able to share that with my physician. So that's the kind of thing that Continua is doing. And these organizations are well established. IHE's been doing this in healthcare space for more than a decade. And it's got a process where we start with the use case, we identify the standards, how do we pick them? That process that I showed you, that one-page process, that process was developed based on information that was coming from IHE and how it used its process to select standards, as well as work that had been done nationally in the U.S. and elsewhere by other profiling organizations. Same process used to identify standards. We take that and develop technical specifications. So Sunday night from about 12 to about 3 a.m., I was finishing up the data access framework white paper for integrating the healthcare enterprise. Okay? So develop this technical specification. It goes out for public comment, public healthcare providers, vendors, anybody who needs to use this comments on it. We take feedback. We make changes to it. We test it. January. I was in an absolutely lovely place to be in the middle of January in downtown Chicago. That's like saying I really want to be in Saudi Arabia in August in terms of weather, except for the weather is completely the opposite. All right? Instead of it being 40 C, okay, it's negative 40 F. I'm kidding you not. It was down to negative 15 one day while I was there. Very, very cold. We do demonstrations. You're going to see demonstrations at HIMSS Jeddah. If you've ever had an opportunity to make it to HIMSS in the U.S., you should go. You'll see there's a whole huge interoperability showcase. It's an acre. Let me give you an idea of how big an acre is. This room is maybe a quarter of an acre. Okay, maybe a third. All right, imagine coming to a floor that big, and all over the place there are computers and they're talking to each other. Demonstrating products using IHE. Then there are integration statements, published statements by vendors that say, I conform, that get tested, and then, of course, this is a repeating cycle. IHE's been going on since 1998, so I'm a little behind on my dates. We're now like 15 years into IHE, not more than a decade and a half. I spend most of my time in patient care coordination. I've been a chair of that committee for the last 8 years. I resigned, my term ended last September. And since I was entering Bill's program, I decided that I wasn't going to run again because I needed those cycles to focus on my informatics degree. So I'm going to wrap this up real quick. IHE deployment committees, that's your IHE Saudi. That's dealing with deployment. We're going to be doing a bit of a kickoff in Jeddah, that pre-conference workshop that I talked to you about for that. And IHE also formed an IHE services group that's building testing tools. Guess who's building the testing tools for the ministry? For their eHealth program. So to bring it all together, why is it important to know about HL7 and IHE? Well, these are the key standards for eHealth here in this country. And there will be more coming. Okay? We've got work currently going on, developing. Some of this material here applies to that work. So here's my invitation to you. It's extended for me, but I've also been given permission by the Ministry of Health to invite you to these events. We will be holding workshops next month, starting actually at the end of the current month, so Jumada al-Awwal, if I said that correctly. Okay? And we're in the year 1435, right? Did I get that right? Okay. I always put both dates down on my workshop presentations. So the end of the month will be a workshop on medications. We changed the track from pharmacy to medications. It's about e-prescribing and e-dispensation. We'll be holding another one at the beginning of April on immunizations. Same week. These two are in the same week. The following week, I will be holding a workshop on clinical summaries. Okay? So if you want to hear about CDA and the implementation specifications that are being developed, you're invited to attend that. I will be staying the week and through the week going to HIMSS Jeddah. There will be a pre-conference or post-conference meeting. Presently planned to be pre-conference, but we may move it around depending on what we can get. The SASO standards activities are going to kick off, and there will likely be a formal announcement about that on that date. Then following, we have HIMSS Jeddah, and then we have the e-referral workshop. The workshops are all going to be in Riyadh. So if you're here, if you would like to attend the workshops, please contact me. You'll be able to get my contact information. It's keith.boone@ge.com if you want to send me an email. If you find me on Twitter, it's @motorcycle_guy. But feel free or talk to one of your teachers or instructors who can put you in touch with me. Or I can also put you in touch with folks at the ministry so that you can get the invitation to attend. But you are all invited to attend these activities. And we hope later to have in this year this first annual meeting of HL7 Saudi, inshallah. And I say that, truly, God willing, I really want that to happen, that HL7 Saudi becomes something that enables you to learn more about HL7 standards and be able to contribute to the development of Saudi standards and customization of HL7 standards for the country. So these are the coming events, references here. So thank you, shukran. I think that's my last word in Arabic, and I'm sorry I've run over just a little bit on the time here, but I could take maybe 2 questions.
Yeah.
And you can feel free to ask me any questions at lunch as well.
Thank you, Mr. Boone, first for the excellent